This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to our podcast on the abdominal aortic aneurysm, or AAA. So with me today, we have a special guest, Dr. Adam Beck, who's professor of surgery and division chief of vascular surgery at the University of Alabama Birmingham. So Adam, thank you very much for joining us today, and thank you for taking the time.
Thank you for having me.
Well, each year, approximately 200,000 people in the U.S. are diagnosed with abdominal aortic aneurysm, or AAA. It's estimated that more than 1 million people are living with an undiagnosed AAA. In 2019, aneurysm and rupture were responsible for over 17,000 deaths. The number of aortic disease has been increasing over time, particularly due to aging population, better diagnostic modalities, and increased awareness. Aortic aneurysm are broadly classified by their anatomic involvement, with AAA being the most common and most likely to be caused by atherosclerosis. Left untreated, abdominal aneurysm can rupture and carry a mortality of more than 90%. The clinical burden, coupled of the often silent, insidious, and unpredictable nature of aortic disease, necessitates better clinical understanding of the mechanism of the disease and the modifiable risk factors. So Adam, let me fire up a couple questions, for you. If you could define for us what is an aneurysm and why does an aneurysm form, and why the abdomen?
An aneurysm is basically a weakening in the wall of the blood vessel, which allows the blood vessel to balloon up, if we put it in the simplest terms. There are a few different types of aneurysms that are basically described based on their shape. So basically, you can have an aneurysm in any blood vessel in your body. The most common places to have aneurysms are in the brain, in the arteries in the brain. The second most common place is in the aorta. The aorta is the largest blood vessel in your body, or the largest artery in your body anyway. And the most common place in the aorta is in the abdominal aorta, as you said. And about 80 or 85% of aneurysms are below the renal arteries, the arteries to the kidneys. There's a number of different theories about why the abdominal aorta is more common than other portions of the aorta. One of which is the content of elastin in the wall of the aorta. So if you look at the thoracic aorta, it has a lot more elastin in the wall than the abdominal aorta. There's also some small blood vessels that actually provide blood flow to the arterial wall itself. They're called vasovasorum. And for whatever reason, there's much more vasovasorum in other portions of the aorta than there are in the abdominal aorta. And so some investigators think that sort of less density of blood flow to the wall of the artery makes it more likely to dilate over time and more susceptible to the damage that can be caused by atherosclerosis.
How frequently is that? How common is it in men and in women?
Much more common in men than women. It can be upwards of 5% of men, and it depends on a couple of different things. Really, the most common risk factor, or the most prominent risk factor, is smoking. So we see aneurysms much more commonly in smokers. There's also a genetic component to it. So if you have a male relative, you're much more likely to have an aneurysm. Or I should say a first-degree male relative, you're much more likely to have an aneurysm. Women who smoke also more likely than women who don't smoke. It's upwards of 4 to 6 times more common in men than it is in women, and it also happens at a later age in women on average than it does in men. So if we were screening people, we would really focus on men that have been smokers at some point in their life.
So does race protect you? I mean, or we're all subject to atherosclerosis and development of aneurysm?
There is an effect of race. So if Caucasians are more likely to have aneurysms than other races, but it's certainly not protective. So if you're a smoker and you have hypertension, other atherosclerotic risk factors, then you certainly can get an aneurysm no matter what your race.
So let's say you have an aneurysm detected. We'll talk about it in a little bit, but let's say you have an aneurysm. What's the natural history? How do they evolve?
Well, the most common, I'll start with when we find them. Typically, we find them incidentally, so that meaning that they aren't symptomatic, so people don't know that they have them. So the most common way that we find them are when people get CT scans or plain films. At least I would say most commonly in my experience is when people are getting worked up for back pain. So they'll get a CT scan or axial imaging of some sort, sometimes an MRI, and the aneurysm will be noticed incidentally. It's less and less common for us to find them on physical examination, which is probably multifactorial. One of the reasons we don't see them as commonly is because of the obesity problem in the United States. So the bigger your abdomen, the more difficult it is to feel an abdominal aortic aneurysm, and the aorta is really closer to the spine than it is the anterior part of your abdomen. So they're pretty difficult to feel sometimes, especially when they're small. The natural history of an aneurysm is to grow, and as they grow, the risk of rupture does go up. So for a man, if the aneurysm is less than 5.5 centimeters in diameter, it doesn't matter what the length is, it's the diameter. That's what confers the rupture risk, and below 5.5 centimeters, the rupture risk is low. It's probably less than 1% per year. But as they grow, they do increase in rupture risk as well. So as over 5.5 centimeters, with the rupture risk is probably about 5% per year. And then as they get bigger, the rupture risk goes up, and that's why we repair aneurysms, is because of that risk of rupture.
They present by other manifestation, sometimes like blood clots in the periphery, or some kind of problem with erosion of adjacent structures, or is that pretty much very rare?
Certainly can. So the aneurysms do tend to have thrombus or clot that form along the wall of the aneurysm, and that is related to the dynamics of the blood flow through the aneurysm. Luckily, most of the time that clot doesn't go anywhere, so it can actually embolize peripherally, and so very occasionally you'll have a patient come in with what we call blue toe syndrome, where they'll have an embolus to their or a small blood clot that'll go into the toe, and they'll come in with toe pain and toe ischemia, and that will be the first symptom of their aortic aneurysm. Very rare though, but I can say I have seen it. We do sometimes have patients come in with erosion into adjacent structures, as you mentioned, also fairly uncommon, but with really large aneurysms, they can actually erode into the spine itself, which can cause chronic pain. And then they do sometimes come in ruptured when they weren't previously diagnosed, and that's actually maybe one of the more common ways that we'll see them is when they present as a rupture.
I guess size really matters there. The larger, the more likely to rupture, as well as to erode. So you mentioned that most of them are asymptomatic. What kind of symptoms are we talking about for people that come symptomatic from an aneurysm? They just come with belly pain or back pain, or how do they present?
If it's unruptured and they have symptoms from it, the most common symptom is just low back pain. And that's just based on the location of the aneurysm, which is a tough problem because people that are at that age very frequently have chronic low back pain anyway. And so it's easy to attribute the pain to the aneurysm, but most likely, and when you fix the aneurysm, the back pain is still going to be there because it wasn't ever related to the aneurysm. And this is really one of the problems with aneurysms, that they are asymptomatic. So they really can be somewhat of a silent killer because patients don't ever know they have it when they come in with the rupture. Now, if they rupture their aneurysm, that's usually much more severe pain. It can cause flank pain, back pain. Sometimes people will have groin pain, which is really a referred pain related to the site of rupture that can be higher up in the abdomen that refers to the groin.
So let's say you have someone with an aneurysm. What's the typical workup? I mean, I know it all starts by the physical exam, and you mentioned that in our patient population, not always that easy. In my career, I've felt a few aneurysms, discovered by physical exam, but it's very rare. I guess, they present to you with an abnormal ultrasound or CT, they.
Mm-hmm. It depends on the diameter of the aneurysm. So if we, first of all, I should mention that oftentimes when we get an aneurysm that's diagnosed with plain films of the abdomen that are done just to look at the spine, because of the physics of the radiation that we use to image the spine, the aneurysm will look much larger than it actually is. And so sometimes we'll get this frantic call about a very large aneurysm, and the patients will be told that it's an enormous aneurysm. They may get told that it's 8 or 9 centimeters, and then we get much better axial imaging, which is a CT or computed tomography scan, and we'll tell the patients, well, this isn't even large enough to fix, and they often will get these kind of conflicting ideas about what to do, and they should know that CT scans are a much better way to look at this. And in 2021, really the best way to look at an aneurysm is a CT arteriogram, which allows us to do a three-dimensional reconstruction of the aorta and get a very accurate size. Now, when the aneurysms are small, when they're less than 5 centimeters in a man, we may just do ultrasound as their primary imaging follow-up, because it's a great way to surveil the aneurysm when they're small. Now, as they get closer to 5.5 centimeters, it's not the most accurate way to measure it, and it is somewhat subject to the person who's actually performing the ultrasound. The CT scan is a much more objective way to look at the aorta and get an accurate size. If we were working somebody up to actually repair the aneurysm, I would typically do a CT arteriogram as a rule in those patients, and would evaluate the entirety of their aorta, because they do have a 5 to 10% risk of having an aneurysm somewhere else in their aorta. So they can have a ascending aneurysm, which is close to the heart, which you may not see on an abdominal or pelvic CT, and you certainly wouldn't see it on an ultrasound of the abdomen.
I guess CT is your main diagnostic tool. You want to get an idea of the whole aorta as well as its relationship with the renal artery, which is, pretty much can help and dictate how you can fix them, isn't it?
Right. So a three-dimensional reconstruction allows us to get a really good assessment of the anatomy of the aorta with relation to the branch vessels in the abdomen, which include the renal arteries, as you said, but also the celiac and superior mesenteric artery, which are the arteries that provide blood flow to the intestines. And we really need to know that for their repair, especially a minimally invasive repair, which is very much dictated by their anatomy. And then in addition to that, we also get a really good assessment of their iliac arteries, and the femoral arteries, which is what we would use to access the aorta and deliver the devices. So we need to know whether we can actually get the devices into the aorta and repair their aneurysm.
Adam, I know let's talk about management maybe a little bit. I know you're a surgeon, but you really care for the whole patient. And a lot of times I think you're involved maybe adjusting some of their medical therapy. What kind of medical management, aside from, I guess, maybe working on their risk factors, can we do on these patients? It's going to be an important part of your therapy, isn't it?
Absolutely. So maybe we could talk about the risk factors. First, I would say that probably the majority of the aneurysms that we see them when they're small. And at that point, really the patients are in the driver's seat in a lot of situations, in the sense that they can actually modify the natural history of these aneurysms by changing some of their lifestyle, improving some of their risk factors, primarily smoking. I spend a lot of time talking about smoking cessation in my clinic. Like I said, it's actually fairly rare that we see patients that have never smoked who have an aneurysm. We didn't talk about patients with connective tissue disorders. Maybe we could talk about that in a moment. But for patients that smoke, the most important thing that they can do is quit smoking, which is really, easy for me to say and hard for them to do. It's a very addictive drug, nicotine, but never in the history of time has anybody died from quitting smoking. So they're not going to die if they do it. But it is quite difficult to do. But I spend a lot of time talking to them about that. I do try to help people quit smoking. I can't make them quit, but I typically will treat them. My personal regimen is to treat them with Wellbutrin and nicotine replacement with patches. I spend a little bit of time talking about that. We talk about hypertension and making sure that their blood pressure is well controlled. I personally try to get people to keep a blood pressure log that they actually bring with them to clinic, so I can look and see what their blood pressure looks like at home and not just when they're at the doctor's office and stressed. They should all be on a statin and antiplatelet therapy, which doesn't do a lot for the aneurysms, although there is some thought that statins may actually decrease the rate of aneurysm growth. But statin antiplatelet therapy does improve their long-term outlook on their health because it does decrease their cardiovascular morbidity and mortality down the road.
How about beta blockers? Is there actually some decrease in the rate of progression of the aneurysm, or has it been validated clinically? Or?
Well, there was years ago, probably about 10 or 15 years ago, there were some trials that were that ended up being a little bit debunked with beta blocker therapy and long-term cardiovascular risk. And for some of the quality improvement that we did in vascular surgery, we started patients on beta blockers fairly routinely, and that has largely been again debunked because it looked like we may be causing some harm. Now, if they needed to be on beta blockers for their blood pressure control, absolutely we do that, but we don't start them on beta blockers any longer as a primary treatment for their aneurysm.
Right. So I think that medical management is important no matter what you do to the patient, and does add a lot of benefit even to the surgery or the procedures that you do, and keep that treatment long lasting, and have, because a lot of these patients die not so much of the aneurysm or the peripheral vascular disease, but of cardiac mortality, don't they?
Right. I mean, more people die with aneurysms than die of aneurysms, and so it is something that we have to keep in mind. And it may be a little bit demoralizing as a surgeon to say this if you really put too much emphasis on fixing the aneurysm. But the truth is if I can get somebody to quit smoking, take a statin and antiplatelet therapy like they should, I can probably impact their long-term health much more by doing that than by fixing their aneurysm. And I tell people that all the time. They really fixate on, us getting a repaired aneurysm, but the other parts of this are equally or maybe more important.
Yeah, probably help your surgical results as well. Well,
absolutely.
Let's talk about our surgical, or let's say our treatment options that we have in the OR or in the hybrid room. First of all, so you've been watching, these people with aneurysm for years. What are the indications for you to say, well, I think it's time to move on and maybe it's time to intervene? What do you watch for?
Well, I'll tell you what I tell the patients in clinic, and if people listen to this and then come see me in clinic, they'll have a little deja vu. But basically, I make the same decision process for every patient every time, and it makes it easier for me. And this is most of what I do is fix aneurysms. The first part that I consider is what's the risk of doing nothing? What if I leave this aneurysm alone? And watch it over time. The second part is what's the patient like? How old are they? How are they frail or pre-frail? What do I think their quality of life is? More importantly, what do they think their quality of life is? And thirdly, what's the risk of doing something? So if I decide to intervene, what is the risk of the procedure that I need to do in order to fix it? And then, as I tell all of my patients, I put those three things together, and everything I do always has to pass the mommy or daddy test. What would I tell my mom or dad to do if they were sitting in that, that clinic chair with the same issues and the same aneurysm? And that makes it an easier decision for me sometimes. So just to go through those things, The risk of doing nothing really depends on the diameter of the aneurysm, the gender of the patient, and where it is in their body. So if we're specifically talking about infrarenal aneurysms, if we kind of stick with the theme of a male patient, we would say a 5.5 centimeter aneurysm has about a 5% risk of rupture per year. So if they live for 12 months after that CT scan and their aneurysm's 5.5 centimeters, we would say 5% risk of rupture. So if we were going to go to Las Vegas and make a bet about whether their aneurysm was going to rupture or not, we would definitely bet that it wasn't, right? There's a 95% chance that it won't. The problem is if it does rupture, they'll die from that. That most people don't make it to the hospital when their aneurysm ruptures. If it was a woman, we would say that around a little bit over 5 centimeters, we would give them the same prognosis. The second part of that equation is what is the patient like? So, the patient may be 80 years old, but they may also still be running triathlons or, marathons twice a year at 80-year-old, or they may be laying on their deathbed from COPD or heart disease or cancer. And if somebody had a terminal diagnosis from cancer, it would make no sense for me to pull them off their deathbed and do some crazy operation on them and then put them back on their deathbed only for them to go on and die from that cancer. So they have to realize that they're going to be the same person when we fix their aneurysm at the end of that procedure. Hopefully not the same person with, some horrible complication of whatever the procedure is that we've done. And that's the third part of that equation is what's the risk of doing something. And so there can be very straightforward aneurysms that we can do an endovascular repair on that may have a mortality of 1% at the time or less with the procedure, or it can be a really, really complicated open operation, a thoracoabdominal aneurysm that involves the branches to the intestines and kidneys, and their morbidity or mortality from that operation may be much higher than that. And we have to put that into the equation as well.
So that's for mostly the asymptomatic ones. I mean, you pretty much watch the size and relate it to comorbidities, look at the patients per se and treat the patient, not only the aneurysm. If they're symptomatic, it's a little different, isn't it?
Right. So if they're symptomatic, or of course, if they're ruptured, the decision process is different. So if someone's ruptured and we don't treat that aneurysm right then they're going to die from that. And, the bottom line is I'm going to die from something one day and you're going to die from something one day. And dying of a ruptured aneurysm is not in and of itself a tragedy. The tragedy is if we've got a patient who has a lot of good quality life left to live and they die of a ruptured aneurysm, then that's absolutely a tragedy. And so sometimes patients come in with a ruptured aneurysm and they may have been at a nursing home with dementia on oxygen, and the family knows, hey, this is okay, if they pass from a ruptured aneurysm. If it's somebody that was walking their dog on the street with the grandkids and they're otherwise healthy and they rupture their aneurysm and they come in with a contained rupture, then that person, we need to get them fixed and we take them right to the operating room. And that may be a minimally invasive repair. It may be an open surgery. It's a much different decision process. And as I mentioned before, it's a different decision process with a very large aneurysm too. Those patients, they have a high rupture risk and may need to get treated very quickly. We do believe that patients that are symptomatic or have rapid growth of their aneurysm, so if they grow more than 5 millimeters in a 6-month period, we do believe those patients have a much higher risk of rupture and we may treat them more urgently.
Mm-hmm. So now you have the choice of treating them, which is, the surgery versus the endovascular technique. And we know that, since you have those techniques, endovascular techniques has really changed the management of aortic abdominal aneurysm. Enough evidence that you can fix the benefits of, I guess we'll call it endovascular repair, EVAR, in elective or even in emergency cases. Most patients that have suitable anatomy will do great with low mortality, but it's not everybody that is suitable, for this type of repair. What goes in the equation? How do you decide, which one should undergo surgery, which one should undergo endovascular repair or EVAR?
It's Part of it is an anatomic decision, meaning the anatomy of their aorta, and some of it is a durability question. And so if you have a very young patient who is otherwise, and for me, very young is someone that's in their 50s or 60s and they're quite healthy, that person may live 20, 30, even 40 years after we treat their aneurysm. And that's really asking a lot of a device that's made out of metal and fabric. And it's also asking a lot of their aorta to sustain, a seal and fixation of that device over 30 or 40 years. We do, as I just alluded to, what we need to obtain an adequate repair is at least at the time of the operation, is we need seal above and below the aneurysm because we're not cutting the aneurysm out. And we need fixation of the device, so it needs to stay put and not move after we put it in there. And so we want to make sure that we seal the aneurysm into good quality, hopefully normal aorta, where the proximal part of the device is, and in the iliac arteries usually for the distal device. If it's a much younger patient, as I just alluded to, and we know they're going to live for many, many years, the portion of the aorta that we've sealed into could become aneurysmal over time, and we may lose that seal and fixation. And so we may lose durability of the device because of that. So the decision is not just anatomic, it's also durability. If the patient does not have anatomy that is amenable to an infrarenal repair, meaning the device is going to land below the renal arteries, there are endovascular technologies that allow us to still repair these aneurysms. They're called branched and fenestrated endovascular devices. And those are, for the most part, are custom-made devices that have holes and branches that essentially let us reline the portion of the aorta that has branches, providing blood flow to the intestines and kidneys. Those are much more complex repairs, and so they're a little bit riskier repairs than an infrarenal repair. Sometimes we can't get the device in there, as I alluded to earlier, so they may have atherosclerotic disease in their pelvis, or they may have really tortuous vessels. Those things go into that decision process too. And then, as you alluded to, we also have to look at the patient. If the patient has good cardiac function, no active coronary disease, they don't have severe emphysema, they may tolerate an open surgery. And so if it's not a straightforward minimally invasive repair, sometimes the best thing to do is an open surgery, which we still do a lot of. I do both open and endovascular repairs. So I do, as I said earlier, I do try to do what I would tell one of my family members to do in that situation. And with that decision process, we typically get good outcomes, thankfully.
Sounds good. So let's say you need to operate on me. I'm 65. I've got an aneurysm, and you're going to schedule my surgery. I'm going to UAB next week. How can you kind of walk me, through it as the patient? What is going to happen when I kind of check in? What happens in the OR, and what is the recovery time and so forth?
Mm-hmm. Well, if you kind of start in the clinic, I guess I would, the first thing, if you came and got a CT scan, or let's say maybe more commonly, I'll walk you through this. If somebody sent me a CT scan ahead of time and it was a really straightforward infrarenal repair, when I brought you to clinic, I probably would just bring you directly to clinic and talk to you about that CT and what it would look like to get a minimally invasive repair versus an open surgery. At 65, you're a healthy guy. I still consider you a young person. And so I would talk to you about the durability of that repair and whether, I thought you should get an open versus a minimally invasive surgery. Most of the time, I would put it in your hands. So I'd give you the risks, benefits of both. And I'd tell you, here are the options. And this is, and I don't really twist your arm to go one way or the other. If you had anatomy that was not straightforward for a minimally invasive repair, I would probably have you have an echocardiogram the day of your procedure, which would give me some idea of what your cardiac function looks like, and an EKG, so I can look and see if you have any maybe hidden coronary disease that you didn't know about, or if you'd had an MI, a heart attack before. And that, if you had any diminished cardiac function, that might push me towards a minimally invasive repair versus an open surgery.
I'm in the clinic, but now you're scheduling me for surgery. What should I expect?
Yeah, so if you were going to get a minimally invasive repair, we usually bring you in the morning of surgery. You check in. I see all my patients before they go back to the operating room. If you're getting a minimally invasive repair, we have, like most big modern hospitals, we have hybrid operating rooms, as you alluded to before. The hybrid means that we can do minimally invasive procedures with advanced imaging or an open surgery in the same room. That's all that means, is we can do both open and minimally invasive surgery in the same room. We use some advanced 3D overlay imaging for my minimally invasive repairs, which mean that we can actually fuse your preoperative imaging to your intraoperative imaging, and it's essentially like playing a video game, because we can overlay your anatomy with your intraoperative imaging, which makes the repair much more straightforward. If you were getting a straightforward infrarenal stent graft, you usually get that done through small, about 1 centimeter incisions in your groin. I do it under general anesthesia, mostly because patients want to be comfortable, and using the 3D overlay imaging, we have to keep them perfectly still. If the procedure goes well, most people go home the next day. So we get them out of bed and they walk around, and as long as they do well, we send them home the next day. If they get a more complex branch fenestrated repair, it really varies from anywhere from 2 days to up to 5 or 6 days in the hospital for people that get procedures like thoracoabdominal repairs, which is kind of a whole different can of worms to talk about. If you were getting a infrarenal open aortic repair, we usually place thoracic epidurals in the morning, or regional pain specialists put in epidurals prior to the procedure to help with postoperative pain control. And people are on average are in the hospital somewhere around 6 to 8 days after a procedure like that, mostly awaiting return of bowel function and control of their pain, and get them to a point where they can eat regular food, take oral pain regimen, and are ready to go home after the procedure.
So, so that's a long time in surgery and as well as in recovery, isn't it? I mean, it seems like if you do an endovascular repair, not only I'm home, the next day, but probably back to work the following week versus maybe several weeks,
right.
Open surgery.
Yeah, that's a great point to make, is that what you achieve with a minimally invasive repair up front is lower morbidity, so less risk of complications, lower mortality, less risk of dying from the surgery, and you lose in durability. So if you trade that upfront risk for the knowledge that your aneurysm is gone with an open surgery, that portion of your aorta has been replaced by a new tube. Cannot become aneurysmal again. Now, the rest of your aorta can become aneurysmal over time, but the portion of your aorta where the aneurysm was is gone. And with a minimally invasive repair, the aneurysm is still technically there. But if we've got a good repair, the aorta will remodel around that stent graft, and the aneurysm will go away, or at least stop growing. We just, again, hope that stent graft remains durable. It doesn't fracture, fatigue, and then it stays in place, and it doesn't need any revisional procedures down the road. If you live 10 years after a minimally invasive repair, you have about a 15% risk of needing additional interventions. Most of the time, those are to treat endoleaks, which is a whole different subject. I don't know if you want to get into that subject or not, but endoleaks it's a really unfortunate choice of terms that the doctors have used for years since we created endografts. But endoleak sounds like you're leaking blood out of your aorta, which is not what's happening. You're actually leaking blood into your aorta, into the aneurysm. Some endoleaks can be very benign, some can be dangerous, and we have to keep an eye out for those. You do have to get axial imaging, CT scans for the rest of your life to make sure that you don't develop endoleaks, and that's another trade-off of open versus minimally invasive therapy. So if you have a EVAR or endovascular aortic repair, I usually get a CT scan 1 month after the procedure, 6 months, and then yearly thereafter. If you get an open surgery, if the rest of your aorta is normal at the time of your repair, I get another CT scan at 3 years after your repair. And if you have no evidence of any aneurysmal dilation of your aorta, then we ask that you get another CT about 5 years after that. So less doctor visits if you get an open operation. So all of the risk really is at the front end of that.
Well, I think the endoleak is a problem. I think I had a patient of mine that I sent to you that had one of this problem where the aortic, the abdominal, sac kept growing, and I guess it's sometimes it's where the graft is attached to the aorta or where it ends, or sometimes it's from these you have the lumbar arteries that are coming from the back that are still kind of perfusing the sac. How do you control that?
Right. So there are different types of endoleaks, just like you said. So as I mentioned earlier, to get a successful minimally invasive repair, we have to have seal at the top of the graft, seal at the bottom of the graft, and fixation so the device doesn't move. So one type of endoleak is what we term a type 1 endoleak, and that is if you lose seal at the top or bottom of the graft. So there's a type 1A and a type 1B endoleak. A type 2 endoleak is just what you just mentioned, is leaking back into the aneurysm through branch vessels that have been covered by the graft. So everybody has lumbar vessels that arise from the abdominal aorta. You also have something called an inferior mesenteric artery, which may be open at the time of your repair, and all of those blood vessels can back feed into the aneurysm. A type 2 endoleak is less dangerous. Most of those go away on their own, but sometimes they stay open, and sometimes the aneurysm will grow. A type 3 endoleak is either a defect in the graft itself, where you get flow through the graft into the aneurysm sac, or you can have a separation of the components of the device if it's a modular device, and most of them are modular. A type 1 and a type 3 endoleak are both dangerous. So if you were to put a catheter into the aneurysm sac and measure a pressure, the pressure will be just like systemic pressure, and that endograft has done you no good. So you have the same rupture risk as if you hadn't had the aneurysm repaired at all. And so those are endoleaks that we usually try to treat very quickly if we can, because that patient is at risk of rupture.
You put another graft, or what do you do?
It depends. So if you have a type 3 endoleak where the components have separated, or there's a hole in the graft, sometimes we can very simply just reline the endograft. Unfortunately, the type 1 endoleaks, especially type 1A near the top of the graft, can be a much more challenging situation to fix. So sometimes we have to extend more proximally in the aorta. It can be as simple as just putting a cuff that seals a little bit higher below the renal arteries. But most of the time when I see those patients, that's already been tried, and we have to line through the portion of the aorta that has branches to the intestines and kidneys and do a fenestrated graft, as I mentioned. And more, we have endograft failures that require an open conversion, meaning that we have to do an open surgery, take out all or portion of the stent graft and do an open surgery. And that, because of all of the minimally invasive repairs that have been done over the years, there are a lot of patients walking around with stent grafts that are failing. And because the stent graft is in there, it can be a very challenging situation, sometimes not doable with a minimally invasive repair. So sometimes we have to do an open surgery to treat that.
So that's something obviously to balance in the equation, as you mentioned. Let's talk a little bit about the open surgical repair. I mean, it has a pretty low mortality also. I guess you do that in younger people that, you feel in better shape. So the mortality is less than 2%, but there can be complication also that can follow surgery. You can have pseudoaneurysm or graft infection. What kind of complication do you have, and how do we manage them?
There's kind of short and long-term complications of an open surgery. So, and having good outcomes with open surgery is very much predicated on good patient selection. And so, as we talked about before, the ideal patient for an open surgery is a younger patient with less cardiopulmonary complication or morbidities. So they've got a good heart, good lungs, good kidneys, and those people usually do very well. And I would, in somebody that's got good cardiac function, no coronary disease, no COPD, either as a quit smoker, never smoker, stop smoking at least a couple weeks before the surgery, I would quote them a 1 or 2% risk of mortality. Now, that patient is uncommon. So we very often see people that have COPD. They have known coronary disease, have had coronary bypasses or coronary stents before. That's a much more common patient. And so the more complex the operation and the more complex the patient, the higher risk of the surgery. Sometimes we can't do a minimally invasive repair. We just simply can't do it. And for a number of reasons, that some of which I've mentioned. And the only option may be a high risk open surgery. And I have a very frank conversation with my patients about a high risk open surgery and what the risks are. But sometimes, a high risk surgery is better than the risk of rupture, which may also be high risk. The early complications of an open surgery, if we have to clamp above the renal arteries or above the intestinal arteries, there's a risk of renal failure around the time of the operation. So patients can go have some kidney failure, which may be short-term or permanent. It's most of the time it's short-term, and most of the time patients don't require dialysis, but you can. Bleeding, because it's a big surgery, and we do have to give blood thinners around the time of the operation, so patients can have postoperative bleeding. Heart attacks, if we have to divide the diaphragm, the risk of having pulmonary complications and ending up on a ventilator for a period of time is a risk, especially if the patient has COPD. That's actually one of the more common risks if the patient has COPD and we have to do a 2-cavity operation with incision into the chest. So those are some of the early risks. Some of the later risks are things like a hernia in the incision. If it's a transabdominal operation, they can get adhesions in the bowel and get a bowel obstruction. Those are a kind of a 5 or 10% risk over time. Probably hernia is actually higher than that because patients, especially if they continue to smoke, have a tendency to get incisional hernias, and people that have AAAs have a higher risk of getting incisional hernias than the average patient as well, probably because they have some some problems with wound healing, or they're just their tissues are not as strong as the average patient.
Problem with the weight, obesity, diabetes, and
right.
COPD really doesn't help. So these are difficult options. But overall, I think great results in patient selection is so important. So these are for the chronic aneurysm. Let's say for acute rupture. I mean, if I'm in the ER, I know my management would be to insert 2 large bore IV and give you a call and probably get an ultrasound. I guess that's the best thing I can do. Do you manage them mostly with endovascular now, or do you prefer open, surgery? You don't have that much time to evaluate them, do you?
Right. So ruptured aneurysms come in a few varieties. If they are a more local patient, we live in an urban area, so we may get patients who come in with an infrarenal ruptured aneurysm, and patients definitely do better with an endovascular repair if they have good anatomy. We can often whisk the patient off to the operating room and get a stent graft in within 30 or 45 minutes and get control of their aorta much more quickly than that. That's sort of one flavor of clinical presentation. The more common thing that we see is a patient from, 300 or 400 miles away who's got a very complicated anatomy. The doctors there don't think that they can get an endovascular repair, at least with an infrarenal device. But the patient, they are ruptured, but it's a contained rupture. So the tissue around the aorta has kind of contained the blood, and they send them to us they'll fly them to us. Patients maybe a low blood pressure, but they're stable. And in those patients, sometimes we can do a minimally invasive repair by modifying a device and creating a device that will fit their aorta. We call those physician modified endografts. And then also sometimes we do an open surgery for those. And I would say more commonly we do an open surgery in that situation. And believe it or not, we get really good results with that. And I think part of the reason we get such good results is the patients have sort of self-selected. They survived their initial rupture. They've stayed stable for travel 300 or 400 miles, and so they've kind of demonstrated that they're gonna be able to tolerate an operation like that. But the risk of mortality after a emergent presentation like that is absolutely way higher than it would be if a patient comes in electively.
Well, I know you've done some special training in endovascular therapy, even in the Netherlands when you were doing your fellowship training, and you're still doing a lot of research, I think, in that field of trying to kind of build a new endovascular device, maybe to kind of fit, particular patient anatomy and condition. What else is happening in research in that field?
There are, all of that is true. There are a number of companies that are interested in producing branched and fenestrated devices. There is one device on the market that is a fenestrated device that is custom built for the patient's anatomy. That device has a lot of engineering constraints. It's only intended for aneurysms immediately below the renal arteries, what we would call a juxtarenal aortic aneurysm. And so and the devices have to be custom made. And so they take 2 to 3 weeks to order and have the device available. So it's certainly not something that you could treat an urgent or emergent problem with. For patients that have aneurysms above the renal arteries, there are a few trials that are ongoing by a couple of different device companies that can be used to treat that type of aneurysm. Sometimes those are not. The patient's anatomy is not amenable to a device like that. And so I have a investigational device exemption study that is what's called a physician-sponsored investigational device exemption, or IDE, with the FDA that allows me to both modify a graft if it's an urgent or emergent problem, like I mentioned earlier, or order a device for those patients. Those devices can take upwards of 2 to 3 months to plan and obtain. They're built for the patient specifically in Brisbane, Australia. So they do take some time to get back from Australia and ready to implant. But we do a lot of those, and we can treat juxtarenal, suprarenal, and even thoracoabdominal aneurysms with those devices. And there's a lot of exciting things going on in the aortic repair world. This is there are also aneurysms that can develop in the arch of the aorta, so where the branches to the brain and arms come off of the aorta. That's really one of the sort of frontiers in endovascular aortic repair, and we do have some ongoing clinical trials for that as well. And so we do a reasonable amount of that at UAB. Those repairs are done in collaboration with the cardiac surgeons at UAB, so we have a nice collaboration with them. Really, there's not anything that you can do to an aorta that we don't do at UAB. So I'm very proud of that. And I think that if, patients with really any portion of their aorta diseased, we are certainly interested in seeing them.
Yeah, I've seen some of the work that you've done with Kyle Udaly on the using the elephant trunk, aortic prosthesis and thoraco-abdominal aneurysm. Pretty phenomenal. You can reconstruct a whole aorta. Well, we've talked about the repair of these aneurysms. Obviously, when you get into the rupture, very frequently it's too late. And so what we want to do, obviously, is increase awareness and try to detect those aneurysms, earlier. And for that, we need to screen abdominal aortic aneurysm. What is the current recommendation for screening our patients for aneurysm?
Not that much. So there's a very specific patient population. So if you're 65-year-old man and you've smoked more than 100 cigarettes in your life, that's the patient that is recommended to get screening in the United States. So those patients will get a welcome to Medicare ultrasound of their abdominal aorta, and the pretest probability of aneurysms is highest in that population. That said, that is not a adequate screening for a thoracic aortic aneurysm. You can't see the thoracic aorta in the chest with ultrasound because of the lungs. And if patients have a significant family history, so multiple first-degree relatives who have aneurysms, I personally recommend that they get axial imaging of their entire aorta, and that may just be a non-contrasted CT of their chest, abdomen, and pelvis. When they're in the 50-55 range, just to look for any dilation of their aorta. Also, if they have a history of both thoracic and intracranial aneurysms in their family, that those can be genetically linked. And so we may want those patients to get screened. And then the one thing that we haven't talked about much that I alluded to earlier is connective tissue disorders like Marfan syndrome, Loeys-Dietz, Ehlers-Danlos, and then some less common connective tissue disorders. If someone has a family history of those conditions, then it's a good idea for them to get their aorta screened as well.
In women also, if they have the family history and they smoke?
Yes. They won't get a free ultrasound that way, but if they've got a significant family history of first-degree relatives, so a brother, sister, mother, father, grandmother, grandfather, if they have multiple family members that have had an aneurysm, especially if they smoke, it's a good idea for them to get screened. And they can usually it would be their family practice doctor or primary care physician that would do that for them. And if they're thin, they can just get a good physical exam, also get an abdominal exam. And in a thin person, you can actually feel a normal aorta. It's just there's less and less thin people in the world, unfortunately.
Yeah, exactly right. Well, Adam, I want to thank you very much. I know you're an incredible leader in your field. As a matter of fact, really a lot of people have enjoyed already your YouTube segment, on the abdominal aortic aneurysm, how you explain it, very well. So I think this complements a lot and goes maybe a little bit more into detail of how you fix them. Everything you wanted to hear about the abdominal aortic aneurysm with Adam Beck. Thank you very much, Adam. Thank you for your time.
Thank you very much. Have a good evening.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.